Karen Manning. I am an associate professor at Salem State College in Salem, Massachusetts. And I know we have several students here from Salem State College. I'm also the immediate past president of the Association of Rehabilitation Nurses. And I was here last year at the National Student Nursing Association more as an attendee, but as a sponsor of the conference, and this year wanted to come back and give an overview of rehabilitation nursing. So that's what we're going to do. My specialty is rehabilitation nursing, and actually within rehabilitation nursing, most of my positions have been a management leadership role. I graduated at a time when there was no job. So, kind of similar event that's happening, at least in the New England area, where you guys are having a hard time finding physicians. And what happened is kind of took whatever was available. At that time, I started in an acute care rehab facility. Loved it. Many people who do this route go in it a lot of times by accident, and many never leave it. Because it's an area, as we will talk about, very exciting, very challenging, the acuity is high, so people really love rehabilitation nursing, and plus the patients stay for more than a day, which is also a very nice thing. You get to meet your patients. So I'm going to have Pam introduce herself, and then we'll start.
Hi, I'm Pam Larson. I'm professor and associate dean at the School of Nursing at the University of Wyoming. Is anybody here from the West? Yes. Okay, good. I actually live in Fort Collins, Colorado, and drive an hour and a half to work because I love what I do. I've been a nursing educator since 1985. The 2 weeks after I finished my master's degree, I started teaching in a BSM program, where then got my PhD in teaching BSM program, and also in coordinator nurse educator program with a master's degree. I've been involved in ARN for a very long period of time. My first annual meeting was 1985, and I love it. Right now, I'm the current RNF chair, which means Rehabilitation Nursing Foundation chair. It's the research arm of ARN, and very glad to be on the board, and lots of exciting things to do, which Karen and I will get into how this coming to these meetings grooms you to be a leader in nursing organizations when you get out. And I can tell you, as in the dark ages, as I always tell my kids, I got my BSN in 1969, was active in my state nursing organization, which at that time was in Kansas. Never went to a national meeting, but I would have loved to have gone to a national meeting. So it kind of gets you started, and that's what we need. We need more nursing leaders to replace some of us that are getting a little bit old. Very old.
Okay, so let's get started. So let's start with a case study here. It was a hot summer day that David, a 21-year-old, will never forget. He and his friends decided to skip school and spend the day swimming and enjoying the sun. David and his friends drove to the local quarry. They couldn't wait to take a dip in that cool water. It only took seconds for David to strip to his trunk, race to the ledge 6 feet above the water, and do a forward flip into the water. 30 seconds passed, and his friends thought he was joking. 1 minute passed, and someone yelled, "Where is David?" He has not surfaced. After several minutes, one of his friends jumped in and dragged his limp body out of the water. He did not lose consciousness. His head had struck a large rock unseen from above, causing a laceration on the right side of his head and neck and upper body. David told his friends that he could not feel or move his arms or legs. Responding paramedics placed him in final precautions and transported him to the closest emergency department. Although the name has changed, David is a true story. He was one of my patients. Arrival to the emergency room, his past health history was was unremarkable. Basically, he was a healthy 21-year-old male. There was no history of any neurological disease. His vital signs included a slightly lowered blood pressure, but other than that, nothing of really concern. He was conscious and he was alert. The evaluation in the emergency room, following a physical exam, X-ray, MRI, CAT scan, it revealed that he had no sensation of temperature, touch, pressure, and vibration in the lower extremities. He had no movement of lower extremities during muscle testing. His head, neck control, he did have head and neck control. He was able to shrug his shoulders. And he had some sensation and motion of his upper extremities. No fractures were found in his skull, but he did have a fracture of the fifth cervical vertebrae. Diagnosis, he was diagnosed with a C5 spinal cord injury, leaving him paralyzed. He was a quadriplegic. After 1 week in acute care hospital, David was transferred to an acute inpatient rehabilitation facility for spinal cord injury rehabilitation.
Tag teaming. Acute rehabilitation. How many times have you said to yourself on a nursing care plan or on a case study, I'm moving the patient to an optimal level of wellness, and then you have to explain to your instructor exactly how you're doing that. Well, no other profession, no other specialty takes that to heart so much as rehabilitation. Our goal, not going down here, there we go. I'm just going to go all down here. Our goal is to restore that person to their maximal level or optimal level of wellness. We use an interdisciplinary approach to do that, and we may be looking at anything from getting that person to walk again, like for instance our previous case study, although that's not the case with him, but getting him to be as independent as possible. Many of you have gone to school to make a difference in nursing, and nothing can make a difference like rehabilitation nursing, and you truly do make a difference. The rehabilitation nurse cares for those that have temporary impairments, the people that come in with the knee replacements, the hip replacements, that sort of thing, but also the permanent ones, the people that have strokes, the people that have traumatic brain injury, the spinal cord injury. So we look at a whole variety of clients as we do it. And we were there round the clock to assess, plan, implement, evaluate, and coordinate all their rehabilitation care and their medical care. We always, people often think that rehabilitation is just in a setting, and it could be just in a setting, practice just in a setting, like the previous client that we just talked about with the C5 injury. But if we truly believe it, and Karen and I do believe it, it's a philosophy of care, it can be practiced in every single setting. You're always trying to get that patient to an optimal level of wellness. It's just not a setting. It's not setting specific, but it's actually a philosophy of your care that you use with your patients. One of the things that excites me always about rehabilitation, and I got into it being on a neuro unit. This was many years ago in the early 80s, and working with people that had typically stroke, MS, Guillain-Barré, that type of thing, is that you get to know your patients a lot longer. The length of stay is much longer. I'm not one of these fast and dirty people that I want to get this patient in and get this patient out. I want to have a relationship with that patient. That's why I became a nurse. That's why I care about it. I will know that patient and I will know that family. Well, nothing's going to be able to give you that opportunity like rehabilitation nursing. We have lots of different roles as a rehab nurse. The main ones we think of, the second one here, it comes to mind right away, caregiver, but we're always giving care, that type of thing. But there's a lot of education for both that client and also the family, too. You're teaching them what they're going to do when they get home to help them be successful. It may be a bladder plan. It may be a valve plan. It may be working with the OT to get them some more assistive devices so they can be independent at home. You're also a counselor. You're working with that family. For me personally, and I think I can speak for Karen too, the psychosocial needs of the patient are much more, to me, almost as important as the physical needs of that patient. I'm one of these, I hate to say, the touchy-feely kind of people that if you may be okay physically, but if you're not okay emotionally, psychosocially, then you're not going to be okay when you get home. So I'm going to be putting on my counselor skills cap a lot of time to be able to work with these clients and families. Okay, caregiver, as I said, you need to be an expert in the techniques to take care of these kinds of patients, and then also have the patience and understanding to work with these clients as they learn to maybe do self-care, be able to dress themselves. It may be a very long process to learn how to, do daily grooming and bathing or whatever it might be. So patience is one of the big things in rehabilitation, standing back and letting that patient thrive. Coordinator of care, if you think about all the disciplines that we use in rehabilitation, you're always going to be coordinating that care. Whether it's working with the PT, the OT, the dietitian, the social worker, or whatever, rehabilitation truly is truly a interdisciplinary approach to care. Patient advocate, I would hope you would always be an advocate for all your patients, no matter the setting. Researcher, that's kind of my little area or bailiwick here, whether it's doing a QA study, whether it's actually doing research, whether it's just implementing evidence-based findings into practice. And the last one is as a legal consultant or expert witness. I have done that a couple of times. I'll be honest, I haven't done it very often because my life is a little full and rich right now. But we do have expertise we share. What is a standard of care for someone in a rehabilitation setting? What's the standard of care for somebody that's in a long-term care setting that's having, that's undergoing rehabilitation? So that could be another role for you. Lots of different places you can practice. We always think about the inpatient rehab unit. That's the popular thing here. But many of the rehab units are just in a regular acute care facility. Maybe an 8 or 10 or 12-bed unit. They may have a very general focus. You may have spinal cord, you may have TBI, you may have stroke patients and everything in between versus some of the big ones. Somebody just came up and said they had a new job at Shepherd in Atlanta, and that's a rehab unit, and she's going to work on the spinal cord injury unit. So, the big specialty hospitals do have individual units. But for most of us, we're going to see more rehabilitation in the smaller units and acute care facilities. You're going to be using your rehabilitation philosophy in home health. What better time to keep that person going, whatever, to think about the principles of rehab. HMOs or private insurance companies often use us as case managers, going in and evaluating the client, that type of thing, very common. Long-term care facilities are trying to beef up their rehabilitation capacities, and I know some of them struggle, and some of you look at it and say, gosh, we're not doing any rehab in that long-term care facility. That's probably a long-term goal for a lot of those facilities, but they are trying to get clients in there and provide the services that they need, particularly for those that are like post-stroke, post-knee replacement, and post-hip replacement. Subacute care units, clinics, schools, government agencies, wellness centers. There's a whole wide area, wide number of facilities that you could work in as a rehabilitation nurse. So what makes it so unique? Because we do use all these different providers. We realize in rehabilitation that none of us has the real answer. In nursing, I don't have all the answers. The OT does not have all the answers. Now, there are some patients that probably think the PT has all the answers. Because when we think about rehabilitation, we think about physical therapy. Well, I tell you, it's much more than physical therapy. So what rehabilitation is we realize that not each of us brings together all the pieces of the puzzle to help that patient back to optimal wellness. And here's a nice little drawing of the interdisciplinary team. And the big thing you notice in the middle is the patient. The patient is actively involved in the care of that patient, in their care, and it also may be their caregivers as well. So, all these other people on the outside are very important. We have a physiatrist over here in the OT and the rehab nurse and all that type of thing, but the patient is the center of care for all of these. Other social workers that wasn't on that nice little chart: therapeutic recreational therapist, pharmacist, registered dietitian. And the other thing I would say about it is that as a rehab nurse, when you sit down with that patient, because they're going to help you determine their goals. It's not one of those places that you walk in and you have an MI or you have congestive heart failure or you have whatever, and the physician, the nurse, or whatever says, well, we're going to do this, 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 and this. That nurse, that physiatrist, that OTPT, look at the client and what are their goals for care? What do they want? And I can think of an example from a very long time ago where we all made the assumption that a patient post-stroke really wanted their speech back. And yeah, they were aphakic, they needed to speak, they needed that, but when you really got down and talked to the patient, they wanted bladder control. Because if they had bladder control, then they could go to church, they could go to the doctor, they could go shopping. Yeah, they wanted speech back. Don't get me wrong about that. But our priority for the patient was very different than what that patient's priority was. So that's the one thing in rehab, you talk to your patient continuously. You are not doing to your patient. They are a part of their care. Collaboration, I already talked about this. We talk about in rehabilitation, it's not multidisciplinary care because that would just mean a number of disciplines working on the care or working on that patient, but it's interdisciplinary care that we are all working as a team and no team member is more important than the other team member. Now I could just yell because I had 3 kids at one time, now I have 8 grandkids. And I do a lot of yelling, and you could probably hear me without this, so I'll give you back.
I feel the same way. My kids on vacation come to school with me, and they'll stay in my office, and I'm teaching down the hall, and they say, Mom, you're loud. And I have no mic, so they can hear me all around the corner and down a couple of corridors. But again, as we said, no other discipline practices cohesively as well in a team as rehabilitation nursing. We really use each other's expertise to be able to provide the care that the patient needs. There are weekly team meetings that are mandated in acute care hospitals. They're mandated by regulation where they sit in a room, talk about the goals, barriers to discharge, what do we need to do to get the patient home. But I've also sat in a team meeting, and it wasn't just about getting the patient home. It was, we have this patient who has a contracted upper extremity, and we're unable to get the patient to be independent, so what can we do? And creatively, a team of us, from physicians to PT to OT to speech to nursing to case managers, really came up with designs, then went back to some of the equipment company and asked them if they could create some of the things that we came up with to be able to suit the contracture this person had and put a bend in it so that they can still dip the food and bring it up to their mouth. So it really is very creative that we will be sitting in team conferences, if only we could do this, if only we had a piece of equipment that did something else, we would be able to get them independent. So no other area really stops to think about that, but in rehabilitation, you constantly are thinking about that. And going back to, certainly started with the spinal cord injury case, rehabilitation nursing for spinal cord. As nurses, depending what area you go into, you certainly, currently have all this knowledge coming at you from everything from pediatrics to maternity to critical care to med-surg. And once you take that NSNA in specialty, your knowledge is now going to be funneled into that specialty area. So working with spinal cord, yes indeed, knowledge about the pathophysiological and psychological implications of spinal cord injury. So, those pieces that you learned in school are going to become a major focus. And yes, you're going to have continued education if you were to go into this area for spinal cord. Certainly, employing and revising techniques to deal with the impact of spinal cord on the individual and family. It's a huge impact. Emotionally, psychologically, the impact of someone having a spinal cord injury, driving up to the quarry, diving into the water, and then having a completely different functional ability within minutes is something that rehab nurses have to deal with. I can't take away the spinal cord injury, but I can help that person deal with spinal cord injury. I can help that person become as independent as possible and live with that spinal cord injury, back to work, back to living, back to playing. That's what I do. I get them back to that point. Certainly, other things that rehab nurses, spinal cord, assess, diagnose, implement pertinent care that you would do in any area. Plan individualized according to the patient's ability, according to their age, their developmental ability, and if there's any other coexisting conditions that the patient may have. And certainly that our plan reflects current research and that we incorporate the current practice of spinal cord injury into our plan of care. So as a rehab nurse, I need to know what their functional ability is. I know David was diagnosed with a C5 quadriplegic. I do know as a C5 quadriplegic, he's able to move his head, he's able to shrug his shoulders, he's able to bend his elbow, and he can turn his hand. But that's about it. He does not have anything else from the lower part of the body. But again, working in that specialty, you will learn exactly what their functional abilities are. Knowing what their functional abilities are, I know what I can get David to do. I know someone who can shrug their shoulders and bend their hand. I can get a face cloth in their hand and then they can wash their face. I know if they can bend their arms, I can get a spoon and they can feed themselves and they can become independent. I know he can bend both arms and he has limited use of the palms, but if I was to put pegs on the wheelchair, he probably can propel a manual wheelchair maybe 200 feet if it was a smooth surface. But I know being a C5 quadriplegic, he really needs an electrical wheelchair with hand controls, not a sip and puff wheelchair. I know he can do it by hand control. He has that ability. Those are the type of things that we would just immediately know in a spinal cord. I know spinal cord, the brain, the master computer of our body, now has the cord that goes down, the spinal cord that relays the signal is interrupted. That the messages are not going down. I know the messages are not going to be down to the bowel and bladder. I know that David's going to have neurological bowel, and he's going to have a neurological bladder. I know he's going to need to be straight passed. I know he's going to have to be put on a bowel routine. These are things that working in a specialty, that knowledge that you had in school and funnel would be something that you would become an expert at. Certainly, skincare, that I would teach David how to be able to take care of his skin. He has enough functional ability that he can lean his body over to one side of the wheelchair just enough to relieve the pressure, next time over to the other side. He has enough control to do that. He has enough control to do a self-assisted cough, where he can press on his own stomach or just lean forward and just to get enough pressure so he's coughing, increase that lung capacity. So other things that I've been looking at, certainly again I mentioned that psychological impact, how he's coping, looking at if there's any pain issues, what equipment we need at the home. I certainly know he needs a wheelchair. He's going to need a ramp to get into the house. He's probably going to need his whole bedroom reorganized so a wheelchair can get in there. He may need a special bed, a special mattress. All of those things are things our whole team is going to look at. And certainly, as Pam had mentioned, going to spend a lot of time on education. Educating, he has enough hand control that he can straight pass himself with special equipment. So those type of things, we will be educating him, educating how to continue to take care of himself, but also how to prevent something else from occurring, urinary tract infection, a skin breakdown, respiratory infection. So for David, his course, while in rehab, he did become independent with eating, drinking, washing his face, brushing his teeth, shaving, and hair care after the equipment was all set up. He didn't necessarily go and get it, but once brought to him, he was independently able to complete all those tasks by discharge. He was able to independently use his power wheelchair, and again, shifting his weight, assisting coughs, and he had a positive attitude. He had a great support system, so he had lots of people who were out there that were able to help him. And he was transferred home. He was transferred home. He was able to go through a driving program, but certainly ended up buying a special car that had the hand controls and became independent, returned to college. The other thing about rehabilitation that I mentioned and Tim mentioned is you do get to know your patient. Almost, I would say, a good percentage of every patient that I've taken care of, and it was a lot of patients considering I have been in rehabilitation over 25 years, come back. And I've had them say to me, I know I was in the acute care hospital, and I'd love to go back and thank them, but I don't remember anybody there. And because they're in and out so quick, but they get to know their rehab nurse very well. So they do tend to come back, they do tend to send thank you cards, and you do see the progress that they make. Sure.
Did he do his own, five-word transfers to go in and out of that wheelchair, or?
He did not.
Did not, so he was happy to sit in that wheelchair, and was he describing the car that was set up exactly for him, like how did he get in and out of that?
He had a car that was set up, so let me take that back. In the car, he was absolutely able to slide over just the way the car was set up into the seat. We did not need someone. His bed he had difficult, but many chairs he did not. His bed had a special mattress that he was unable to independently go into the bed. And that's not uncommon for someone who only has limited ability of the hand. If he actually was just one vertebrae down, he'd be able to go in and out of bed no problem. It's that difference between the 5 and the 6. So if it was a soft surface like a bed, he needed assistance. If it was a mat on a PT gym, he could do it. So it all depends. With the car, he was able to get the wheelchair right up against the passenger seat and go over. It was actually a regular van that just brought him up, and again, he was able to line it right up. Oh, yep.
What's the duration between his actual accident and ability to go back to college?
So from the time of his accident, 19 years of age, he was a college student. He ended up missing one semester. One semester only. He was at the beginning of the semester. He was in the hospital for probably 3 months and returned to that semester. He had motivation plays a key role in rehabilitation. So he really was motivated. He had friends that came in, very supportive family. That next semester, he was able to jump right back in. And some will only miss a year because when I first got out of nursing school, the average length of stay for a spinal cord was 6 months, some of them a year. Now it's just a month, 2 months, depending if they're flawed. and we're just moving things along so much quicker. But, the patient that was in the med-surg hospital 5-10 years ago, IV antibiotic, blood transfusion, the vent, the telemetry monitoring is in rehab. All that equipment's in rehab, in acute rehab, because we're getting them up, walking, they get the telemetry on, they're getting their blood transfusion, they don't have, with insurance, we can't send them back to the acute care hospital, so we're doing all that type of stuff in an acute rehab setting. So our next case study is Johnny, a 6-year-old boy who was injured in a motor vehicle bike collision. Johnny was struck by a truck while riding his bike on a quiet street in front of his house. He was thrown 20 feet and struck a tree. The driver left the scene of the collision. Johnny's mother witnessed the collision and immediately ran to him. Johnny was unconscious, bleeding from his ears. He was taken by ambulance to the emergency department of a local hospital and stabilized. Again, Johnny's name is different, but again, another patient that I had. Diagnosis, traumatic brain injury. So absolutely, it had an impact to the brain, swelling, bleeding that caused injury. While at the acute care hospital, Johnny was seen by a team of pediatric specialists, so certainly from physicians to respiratory to neurological pediatric specialists. He underwent an operation to remove the subdural hematoma, and after 2 weeks, he regained consciousness and was transferred to rehabilitation. So, again, just 2 weeks later, he's coming to rehab. Rehabilitation, one of the things, a lot of people, Salem State College is probably the only college in the United States that has in the undergraduate program a whole course devoted to rehabilitation. So when I ask my students what they think of with rehabilitation, many of them think nursing home, some think alcohol, and it's much more than that. Yes, there's could be an alcohol rehab component. I myself have never worked in drug and alcohol rehab, but rehabilitation encompasses infants, children, adolescents, young adults to old adults. It encompasses across the entire lifespan. We have nurses who want pediatrics that go into pediatric rehabilitation. Again, your patients are there longer. You get to work with the family, the whole team taking care of that patient. And again, so it becomes a specialty within a specialty. I have myself worked in pediatrics for a while. I was a manager of a pediatric rehab unit. Pediatrics, some of the knowledge the nurses need is not just rehabilitation, because rehabilitation is relearning a skill that has been lost. So pediatric, it becomes rehabilitation and habilitation, not the they've never developmentally reached that age. So you're trying to get them to gain back some things that they lost, and also give enough strength, endurance, coordination to be able to go forward and gain the skills that they need to achieve going forward. So certainly developmental issues play a key role in pediatric rehabilitation. So in caring for Johnny, he has traumatic brain injury. The brain controls everything we do. So, it's allowing me to talk up here. So if there's an injury, it's going to affect my ability to walk. It's going to affect my ability to talk, to concentrate. So certainly a lot of the rehabilitation is going to focus on the physical deficits that someone with a brain injury has, cognitive impairment, behavior. Our brain is what controls our behavior. It it inhibits a lot of inappropriate behavior. So you may have somebody with a brain injury who now has never swore a day in their life, is in the unit, they're swearing, they're grabbing nurses, you know, they're exposing themselves, running around without clothes, because certainly that brain, the impact of the brain is going to affect them. So other things, emotional, social, and personal needs of the individual with brain injury. Again, I already mentioned developmental appropriate care. Therapeutic play. With pediatric, whether it's in a regular pediatric acute care setting or a pediatric acute rehab setting, a lot of the therapy is going to be geared to play. You know, we want to strengthen their leg or coordination. I may be able to tell an adult to, you know, kick your leg 10 times, I'm going to hold you. Tell that to a 2-year-old. You may not get them to do it, but you put a ball in front of them and say, kick that ball to me, and they're going to do it. So it's really trying to incorporate play into therapy. Certainly, the family is going to play a key role. And school, integrating them into school so that tutoring continues right in school so that they never lose anything as far academically and they can continue. One of the other roles for a rehab nurse that many have gone on to is case management. And if I just took Johnny's situation to tell you how actually a case manager or a life care planner, many life care planners in the United States are rehab nurses. Because if I take Johnny, who was hit by a car, and we did find out, and we found out it was a FedEx truck. And a family wants to sue FedEx trucks. How much money do they go for? As a life care planner, and again, specializing in rehab, we're going to know Johnny's 6 years old. Developmentally, he's going to grow. He's going to need a wheelchair, a new wheelchair to accommodate his body until he reaches an adulthood age at about 18 for boys. So probably every 2 years he's going to need a new wheelchair. We're going to factor that in. Johnny's probably going to have problems obtaining a job and keeping a job because of his brain injury. So we're going to factor that in. He's probably going to need group housing. He's not going to be able to drive. So all of this stuff is going to be factored in. Then it's going to go to someone who's going to look at the cost of living as he continues to get older, and that's going to be for the cost of care for Johnny for the rest of his life. But typically a lot of that comes to a life care planner, who many are rehab nurses.
Okay, I get the other end of the spectrum, because in addition to rehabilitation, my other specialty is gerontology, and you will be taking care of older adults as compared to what my students tell me on a regular basis. In the class I teach, I'm going to work in ICU. Okay, one of my students last week said, I was telling Sarah last night, he looked at me and said, Dylan, he's not doing very well. I teach care of the older adults. And he looked at me and he said, you know, I'm not that much interested in your class. And I said, oh, tell me why, Dylan. He said, well, because I'm going to work in ICU. And I just started laughing. I said, Dylan, you don't think you're going to take care of older adults. You don't even know what's going on here. So unless you work in a pediatric unit or you work in labor and delivery, you're going to be taking care of older adults. So people like Karen and I, we baby boomers, are going to be getting old, and we're going to be really cranky too. And former nurses are always cranky patients, so you will be taking care of them. So anyway, my area is the older adults here. So okay, Mary, and this is not a real person. This is a composite of all the stroke patients you can think of known to man. Mary's a 72-year-old female. She has a history of diabetes and hypertension. What do we know about those right away with stroke? Primary risk factor. Hypertension for ischemic stroke, I mean, it's just like the primary risk factor. She begins experiencing a severe headache, followed by slurred speech, right-sided weakness. So what's what does phone tell you what's going on? She's transported to the hospital. She has a number of different evaluations. She doesn't get TPA. She doesn't get a clot buster. She didn't make the 180-minute timeline here. So things are going to be a little rough for her. But we know that stroke is the primary cause of disability in adults in the United States. We know it's the third leading cause of death in the United States. So you're going to be taking care of many stroke patients in every setting you work in. She has a left cerebral vascular accident. She has an embolus that lodged right there in her left cerebral artery. She has right hemopharesis. What else might she have in addition to being a right hemiplegic? What other things kind of go along with this? This isn't class, but this is, because I just taught stroke last week. What?
Extensive neglect.
She could have unilateral neglect. She could also have homocysteine. Anybody know what that is? Remember, you have the deficit.
From both sides.
You have the deficit either right at the optic chiasm or in one of the tracts, and you have this very, very weird vision, which I can't even imagine how it could ever be. You can see peripherally, you can see on the outside of that eye and the inside of this. So you just get little glimpses of things along the way. She's also probably aphasic because the left side here is the front, is for most of us that's the speech center, not for everyone, but for most of us. So she probably is aphasic. She has right hemopharesis. She has homocysteine. She may have unilateral neglect. We also know people with this kind of a stroke too typically act very slow and cautiously towards everything as compared to stroke on the other side. And they have generally, and I hate to say it generally, have more depression associated with it, mainly because the other side of the stroke doesn't realize that they've even had a stroke. And more intellectual deficits usually go along with someone that has right hemopharesis as well. So, okay, so we've got Mary here, and she's doing reasonably okay because in the new days of medicine here, we don't keep patients very long, and she's been 4 days. That was probably a really good deal. Because I'm with Karen, back in the olden days, people were there for months. Didn't go anyplace, and that wasn't a good thing, but this I'm not quite sure this is a good thing either, to get rid of, to send them to rehab so soon. So, as far as looking at different types of diagnoses that you might take care of, and I already alluded to some of these, is you could be taking care of clients that were very neurologically impaired, but then think about the oncology patient, think about cancer rehabilitation. That's something we never really kind of thought about. Think about the patient now that has HIV/AIDS. Do they need rehabilitation? We have a whole new population of people that we never even thought about this chronic long-term care. We can talk about the 6-year-old with a TBI. We can talk about the spinal cord injury. How many people have spinal cord injury lived to be 70 or 80, even 20 years ago? It didn't happen. So we have a whole new population to get these people to optimal wellness that we never even ever considered before. The HIV/AIDS patient that the gay man here or whatever died, 20, 30, whatever it is, these folks now are getting older. We're the new population of older adults that are becoming sexually active that have HIV/AIDS as well. So we've got a whole gamut of things here that we never really even thought possible because our old stereotype has been spinal cord, traumatic brain injury. That's it. And now we're saying, there's a whole lot more out there. Orthopedic, the hip replacements, the knee replacements. A lot of those folks may go to a rehab facility for a very short turnaround time, and that's probably a specialty hospital that may just go to a rehab unit within an acute care hospital. Quick turnaround, maybe it's a trauma patients you're taking care of, an amputation, that type of thing. But the one thing I will tell you about all these people is there are some of us, some of you, some of us, they're not cut out to be rehab nurses. Because there is something about taking care of the patient over a long term that not everybody can do. So you need to figure out, too, if you're up to task. Because this is a patient that's not going to be discharged in 2 days, and you're taking care of them in the hospital, and it's like, you're really beginning to irritate you a great deal. And it's like, and we all have those patients. We have students like that, too. And we even have fellow faculty members that are jealous. Yeah. And maybe I would like to just zap out of my life, but it's not going to happen. So it's not to the faint of heart is what I always say. So I said, okay, I can do this. I can take care of these people. These people are going to be around for a month or so, or you can be able to do it. I think of some of the ICU nurses that I've known in the past, and it's like, my God, we got to get this patient out here, 48 hours, 72 hours. They don't like these people to stick around for a very long period of time. So to be in rehab, you can't be at the faint of heart because you are going to establish a relationship with this patient come hell or high water because they're going to be there in your unit. Okay, Karen and I are both certified rehabilitation registered nurses. Okay, Mary got transferred, like I said, she didn't get a spot buster, so things were a little rougher here for her. But her CRRN explained that she was going to push her to do everything, she was going to make her just as independent as possible through her CRRN. And this is what it is. I've been a CRRN since 1986. How long have you been one? 89. Okay, we're old people, 20 and 20 plus years here. For us, it's a very important part of who we are. And actually, we just recently, our ARE, our Association of Rehab Nurses, has promoted some research that talked about the value of rehabilitation, having a certified nurse. It was a study that was done across the country in, I believe, 52 units. Dr. Audrey Nelson at the VA in Tampa was the initiator of this, and it showed it wasn't really the experience of that nurse, somebody who's been a nurse for 20 years in rehab or whatever, it was that they were certified that made a difference, that decreased their length of stay. So that's certainly, we're really promoting big time here, because there have been very few studies, if any, that I know of, that have talked about, does certification really make a difference? Does it matter if I'm a certified med-surg nurse or an oncology nurse or whatever? And this is probably one of the first big-time studies that showed that it did make a difference. Okay, so the first few days, she's using a wheelchair, she goes to a walker, hopefully, and again, her therapy is 24 hours a day. We're pushing her to be as independent as possible, and we're hoping that she can go home and return to her family.
Okay, so, rehabilitation, the future. The demand for rehabilitation is going to increase. With the aging population, we know we're going to have more and more people who have chronic illnesses and disabilities. So the need for rehab nurses is going to increase. We know with the veterans surviving some of the blast injuries in wars are increasing the number of traumatic brain injuries that we had, and again, the need for rehabilitation nurses is going to increase. So, we gave 3 examples of patients in rehab, but other patients that I have had a 5-year-old who was visiting their cousin in a high-rise in Boston, and they were looking out the window because the ice cream truck was coming down. And one leans they're too hard, fell 5 stories down onto a sidewalk, sustained multiple injuries and a brain injury. It was about a 19-year-old who had finals in college, stayed late in the library. The library was open all night, walking home at 3 a.m. in the morning, assaulted with a baseball bat, multiple injuries, and a brain injury. It's about a 21-year-old who was swinging on a tire swing in his backyard of his house with his girlfriend, enjoying a nice summer evening, when the branch above them broke, hit him in the neck, ended up as a spinal cord injury. It is about a 5-month-old where the baby was crying, the dad couldn't take it, shook this baby so hard, baby had shaken baby syndrome with a brain injury. Rehabilitation is about people like you or I. They got up, they did their normal routine, and something changed their life. Something that changed their life forever. That is what rehabilitation is about. So yes, those injuries, it's also about those who develop chronic illness. Chronic illnesses that just they're going to develop over time, or going to get worse over time. So absolutely, the need for rehabilitation is going to increase. And again, we need more and more rehab nurses. David, the spinal cord injury, who was 19 when he dove off that quarry, he lived to 70. To find out he's diagnosed with Parkinson's. So what we're going to see is those dual diagnoses that also are going to impact rehabilitation or the arthritis that may occur as a result of getting older. So rehabilitation, the need is there. Why choose it for you and it's a specialty? Because rehabilitation nurses make a difference every day, every moment we're there. Patients thanking us every time we're there, rebuilding their lives, building relationships. Patients are acute. We have them status codes. Day 1 from acute care hospital, day 2, increased use of its technology, telemetry. We have cardiac rehabilitation units where all the patients are on telemetry monitoring, where they may be on telemetry monitoring in the gym. Our nurses in the telemetry unit are ACLS certified and lead the code team from both places. Other technology that you're seeing, state-of-the-art research that's happening. A lot of units are now incorporating Nintendo, the Wii, into rehabilitation. So we have our stroke patient who has a balance problem, you know, and you now get them so that they're supported, suspended, and it could be that you put in that they're swimming with the fishes around the sharks or skiing, and just the way that they have to move, that is helping them with rehabilitation. So what other place can you play Nintendo and get paid for it? So, you know, again, different ages, you can specialize in pediatrics, you can specialize in diagnosis, you can specialize in settings, from inpatient settings to outpatient settings. The skills that you need to be a registered nurse. To be certified, as Pam said, you have to have 2 years of practice. Certification just validates the knowledge, and really, it just helps that critical thinking, and it helps with the care of the patient. And again, the study to prove it. And certainly, you can continue on in rehabilitation. Many of the nurses have continued on to be nurse practitioners, specializing in rehabilitation, from education or management tracks. There's many different areas for an advanced nurse. But as the New England area, where I am from, nurses are having trouble finding jobs. One, many of the rehab places are still looking. One of the other benefits is acute rehabilitation is considered acute care experience. So if you ever wanted to go to acute care, they count it as you've had acute care experience and recognize it as the acuity is just as high as in the acute care hospital. So it's no different. But again, jobs are difficult to find. Your biggest skill that you're going to have to hone on and improve is your networking skills. Things like this National Student Nursing Association is important. The Specialty Association for Rehabilitation, the Specialty Association of Rehabilitation Nurses. So it's an organization that actually, the goal is to advance rehabilitation practice. So for obtaining a job in a time when it's very difficult, networking is going to have to become one of your skills, how your business plans that you're going to do to get a job. Because some of the jobs that you're going to obtain is that the people you know or the connections you made, the opportunities that you give yourself. I can't stress that enough. You want an intensive care environment? Well, you know what? Now is the time to see that the hospitals are providing for in-services, getting out there, getting connected. But the same for rehabilitation. Great opportunity. See what's available on the website. What professional associations do, they set the standards of practice for that specialty. And again, Rehab Nursing, the Association of Rehabilitation Nurses, ARN, sets the standard of practice for rehab nurses. It promotes rehab nursing to the public, represents you and your specialty with other associations and organizations, provides continuing education. When you graduate, yes, you will have to continue education, advancing your knowledge, and the associations do that. Provide publications. We have a variety of publications, and I know Pam has been very involved in some of the publications that we have.
Right, the Rehabilitation Nursing Journal, a lot of our research-based articles, a lot of clinically focused article as well. I've been on the editorial board of that before. It's a super journal. It's also online now. I'd also talk about the rehabilitation core curriculum. Most specialties that take themselves seriously, I think that's it, have their own core curriculum of what you need to do to be able to function at an appropriate level in that. And we are on our fourth or fifth edition of our core. Is it fifth? Okay, fifth edition of our core. And I know Karen and I have written in it and reviewed it and that type of thing. So that's one of the things you look at too as you're entering a specialty. Do they have core curriculum? What do I really need to know about this? Now, I guess I would say the thing about the funding for rehabilitation nursing research. Our organization gives away between $30,000 and $40,000 each year in seed grants to folks that are doing small pilot studies and research involving rehab clients.
So absolutely. I mean, it keeps you involved, it increases your leadership skills, and, again, advocate for members both state and federal level. As I had started saying, I'm the past president of the Association of Rehab Nurses. Last year when I was president, I probably spent at least a good 4 or 5 days every month in Washington, D.C., advocating for members of ARN, but for people with chronic illness and disabilities, so from brain injuries to amputation, that I would be advocating at the Capitol. So again, one of the key things is networking. Get to know people, have opportunities. Just by being in an association, I know people across the United States. I can pick up the phone, ask questions. It's such a critical skill to have. And again, in a time where some areas are having difficulty finding jobs. Just for your information, the website for ARN, visit it. A lot of good information up there. And the other thing is, there's a Facebook page that I certainly welcome you to go. Stay connected with Pam and I am linked to this Facebook Association of Rehabilitation Nurses. And certainly for those that are interested in going into rehab nursing, if you want more information, I will be going there and connecting to see if I certainly can help. Again, you're networking. There's many rehab facilities, director of nurses across the United States that I know. The immediate thing is you want to start networking. So, if you want to just link and join the Facebook and start a discussion, I'd be happy to do that. But again, that's going to be a skill that you need more than ever, more than the nurses that graduated 4 years ago that could walk into facilities. You need to have that skill and perfect that skill.
I'm just curious, are there any areas of the country right now that are hiring tons of people? I mean, we talk about the shortage on a regular basis.
Yeah, there's that.
In fact, pardon, Texas is hiring lots.
I know California, depending on where you live.
True.
North Carolina, I know, in New Hampshire, the UNH was suggesting their students go to North Carolina.
No, I just
No?
got, I was used to be dean at UNC Charlotte.
Really?
I just went there.
Well, that's what I had heard, that's what Dr. Fetzer said.
My former colleagues at UNC Charlotte emailing said they can't get jobs in the Charlotte area. Can they come out your way?
Really?
Yeah.
Okay.
Yeah.
Well, I think there's many factors going on right now. One, we do know the average age of nurses into the 50s.
We're old.
We're going to retire, but there are factors now that weren't expected. The economy. So now the nurse that was going to retire is not retiring, so now they're going to work a little bit longer. The nurse who had one job is now working 2 jobs because her spouse is unemployed. So, and then, we certainly have a lot more nurses going, a lot more students going into nursing. It's a temporary situation. I would predict in 4 to 5 years, you'll all be in the area of specialty that you want. But it may not be the one now today. I never left school thinking I wanted to rehab nurse. I didn't even know what rehab nursing was. I went there for no other reason because of an opportunity, and again, it was, I knew somebody. So that networking, I got a job when no one else was getting jobs, and that opportunity led for growth in rehabilitation, opportunities in the association, and networking. So I do think, again, 4 to 5 years you will see something, but again, it's just the economy is playing a factor here right now. Let me open up to any other questions. All right, well, I thank you. A Friday afternoon, after lunch, I thank you so much.